Rob, we may have a small amount of time for questions at the end for all of the speakers. Our fourth and final speaker is Fiona Miles. Fiona's a paediatric intensivist at Starship Hospital in Auckland, and along with that has a particular interest in bioethics, and she's completing or partway through a PhD in that, and has a particular interest in both ethics and clinician wellbeing, and she's talking about moral distress and burnout.
Yes, we just wanted to tease Johnny, actually, because he gave all of us each other's topics. So, I'm going to talk on moral distress, which is Liz's favourite topic, and Neil is a leadership expert, and my PhD is on decision-making. I also like the idea of getting to talk about burnout just before lunch, because I think it puts people in the right frame of mind. Now, which button does this?
The other square control.
No?
A different controller, darling. The big one.
This big thing.
Yeah.
Oh.
Green button.
Green button. Oh, that's really big. Okay. So I'm going to talk about moral distress and burnout, and people I think are a little bit burnt out about hearing about this. When I first talked about this sort of a little while ago, nobody really knew much about it, but in the last year in particular, there's been massive amounts of stuff coming out. So people are hopefully I'll say something you haven't heard before, but if I haven't, tough. Shows you well read. So what is moral distress? Basically, it's a sense of extreme frustration and failure where you feel you're not able to meet the needs of your patient, of the public, and that we're using the wrong resources or inappropriate resources, and that's based on resource use and on communication. This was first described by Jameton in 1984, and then it went sort of quiet for a while. No one was very interested, but in the last couple of years it's had a major resurgence, and now you've got to have a talk on every single conference, so this is the talk for this one. Moral dilemmas are where we don't know what to do, but moral distress is where we know exactly what we think we should do, but something's blocking us. So we know what we need to do, but for some reason we can't do that, and that can be both from personal reasons and from institutional reasons. And what that exists is a massive sense of powerlessness, and learned helplessness is a very horrible feeling, and that's a position that our families are sitting in most of the time when they're in hospitals. And what happens if you have a stressful event, then you build through a process up to a certain level, and then the next time you come to a stressful event, you don't go back to the beginning, you start at that higher level. And so each successive event brings you to a higher level. And for those of you who salt multiple exams, it doesn't get easier, it gets harder, because you know what you're going to have to go through, and you start at a higher level. And they talk about the crescendo effect. Now, recently there's been some studies by Gillian Colville in the UK that say, actually, we're not convinced that this really happens. But because when they study people, they say, people aren't describing this. But that's probably because the people that really were burnt out and had moral distress all left, and so they're no longer there to actually ask. So, moral distress is very common in clinical practice, and it's because you have a perceived violation. Now, there may or may not have been a violation, but the importance is that you perceive there to be. So we can only say things from our perspective. And if you don't necessarily understand what's happening, then you may feel that your core values have been violated, that you feel you can't do ethically appropriate actions. And end-of-life care from previous studies is always top of the list, this feeling that you're doing things that actually aren't the right thing for your patient, that you're going on longer than you should do, or you're doing things because you're scared about being sued, which is a big issue for you guys in Australia. It's not an issue for us in New Zealand because we have ACC. Anyone that wants to come and work, just see us afterwards. So communication is also a very major cause of moral distress, and that's where people feel that the communication has been inappropriate, that there's been false hope. Now, hope is never false. We always keep hope. You hope initially for a cure, then you hope for time, then you hope for peace. So we don't take away hope, but this feeling that we're giving people the wrong messages or not directing our goals of care appropriately is actually what I think people are talking about. And then resource use is always an issue, feeling that you don't have enough staff or that you have the right numbers, but they don't have the right skill mix. And so you're getting people to do things that they're not comfortable doing. So we did Charles Larson in the Australasian group. Australasian means Australia and New Zealand. Australian means just Australian. So I'm an Australasian speaker here today. So the study that we did across Australia and New Zealand, PICU and NICUs, showed that moral distress levels went up with more ICU experience if you were a nurse, but not if you were a doctor. The doctors, the longer you'd been in it, the happier you were. What Charles and our group didn't do was to actually isolate gender out. And in the more recent study by Gillian Colville, she found that actually when you counter for gender, then actually female gender is the most important thing. And that's probably why our results came out as they did. The issue for the nurses is that they're clear about the prognosis, but they're not always clear about why we're doing what we're doing. And talking to our own nurses in our unit, they don't understand how we get to the decisions we make because we don't have them at the bedside. We go away and talk somewhere else amongst ourselves. We don't necessarily communicate why we're doing stuff, and we don't really ask for their input, which I think is a very major oversight. As things become more complex, it's harder to come to decisions, and that's something that Liz has just talked about. These are very complex decisions. There isn't a right or wrong one. And when one of the registrars keeps asking me the same question about why I'm doing something, sometimes say, I've got to do something, so this is what I'm doing today. And sometimes that is our reason. We're not always able to put down exactly why we think this is, but we've got to start somewhere. So nurses being less involved will often see the impact on the families. They're there all the time. We make a decision, we walk away. They're there dealing with the fallout, dealing with the emotional component, and that's a huge thing. So one of the major stresses from our study were that we were prolonging death. So we think we're doing things right, we're trying to save lives. All we're doing is prolonging deaths with our intervention when we know that is the inevitable outcome. And as we get more complex patients and the goals of care actually become a little bit more difficult to ascertain, there are definitely greater expectations. And the world is a different place in the last 2 years, even I think, since Charlie Gard and Alfie Evans. With the great technology and prognostic uncertainty, we really can't be sure about things, and long-term outcomes of cerebral injury is something that John's very interested in. I think we're increasingly aware that actually the only way we know how people are going to be is in retrospect and hindsight. And communication is still poor. Despite all the energy we put into it, we're pretty rubbish at it. Even though if I asked you all how you think your communication practice is, you would all rate yourselves somewhere between a 9 and a 10 out of 10. How are we in real practice? Nowhere near as good at that, but we all do see ourselves as experts. So what's new? I did have, so there's been an avalanche of papers come out and studies come out in the last 1 to 2 years, and they're big papers. In the States, this is a really big thing, across the UK, and in the UK at the moment, they're doing a national moral distress survey of all the ICU practitioners. What's the bottom line of all of them? Because there's an awful lot of them, and I've summarised into one slide for you. Basically, this is present in every ICU and provider group. You may think you're immune, but you're not. Every single person in here will know or be in contact with someone that is either suffering from moral distress or some degree of burnout, which I'll answer Liz's sceptical comment in a minute. So you're looking antsy about this. She's about to publish a meta-analysis on this, by the way. That the bottom line is that female gender overrides your profession or your expertise or anything else. Again, the 3 major things: communication, end of life, and resources. And then ours. The other thing coming out of the States is that electronic health records, which everyone's dead keen on, actually have been shown to increase moral distress hugely because people are spending so much time trying to work out the computer and not enough time with their patients. So they feel it's taking them away from what they really wanted to be doing in that human connection. And so, if anyone's thinking about it, just don't. There is a very major increase in non-medical patient and family needs. So, Liz is a social worker. We've all become social workers. Everyone in the unit's become some degree of social work, counsellor. The medical part of what we do is very small. And as an ICU consultant, I spend my entire time talking, which is great. I love it. But that's what we do. We talk a lot more than we actually do anything else. There's lack of respect from staff and admin, and particularly big institutions, and we are under intense public scrutiny in a way we never were before. And I think that the big cases overseas showed that actually social media drove decisions. And when I spoke to the guys in Great Ormond Street about this earlier this year, they said that actually it was really hard for the staff finding out what was happening to Charlie Gard from social media before they actually found out themselves. And a lot of that was misinformation and very distressing. So what is the problem with this? Well, it results in burnout, depression, and an intention to leave. An intention to leave isn't necessarily the same thing as leaving. Now, Gillian Colville's study, they said that they took a moral distress survey revised, which is they made it a bit simpler and put a few more relevant things in. And the top 3 things for both doctors and nurses is the need to follow family wishes to continue life support, which they didn't feel was in the patient's best interests. Of course, that's an interesting one because it depends who you think can determine best interests, and best interest is a very fraught concept. You can say best interest, and it's a mantra to justify anything you want to do, so it's always a worry, that word. The other worry was about initiating life-saving actions that would prolong death, so actually even embarking on it. And they say that withdrawing and withholding it's the same thing, but in practice it actually isn't. And that you're carrying on looking after people because no one will actually make a decision. So we go into these funny limbos where we put patients into positions while we just work out what we're going to do. And of course you have to do that to some degree in ICU because you don't know what's going to happen, but you also have to be intentional that that is what you're doing. What are your goals of care? So no matter what you're doing, you can always agree on your goals of care, and that's looking at the values rather than the actions, and that's a really important difference. And there's a couple of less interesting things under. So what stops us? What stops us from speaking out? Well, there's the personal things where you think, well, maybe I just got it wrong, or these are clever people. I'm not going to talk about this because they know better than me. I'm not in a position to speak up. I always do what I'm told. I actually have no idea what's going on. Then there's the institutional thing where you think, actually, I'm not safe to speak up. And the whole idea of psychological safety, it's a great phrase, but it's actually not, you don't always feel you're in a position where you can speak up. And I'm not talking about our junior nurses, I'm talking about someone at consultant level. There are times when I might want to say something and don't, believe it or not, John. So I think that goes across the board. So barriers in our own ICU, I looked at what people had commented from our own ICU when we did the study, and why don't people come to counselling? Why don't they come to the debrief sessions? Well, they weren't staffing. They couldn't make it off the floor because they were too busy. The debriefing sessions were set for when that suited the medical staff. It actually didn't fit nursing staff. It was their day off. They didn't want to spend their one day off coming in for this. Parking. You know, you want to get passionate in hospitals, talk about coffee and car parking. And trying to get a car park wasn't worth it. And also, we still have this pervasive culture that if you need support, you're weak. You know, we are too strong. We are still staunch. You know, if you mention that you need counselling, then it's like, oh, what's wrong with them? They just need to toughen up. And we will all think it at some level because we are so trained in to do that. And there's a big concern about confidentiality. Someone will hear that I wasn't coping. They will then see me differently? And so that is a big issue. So what's the cost of that? Well, this is Liz's favourite thing, burnout. Burnout is real, believe it or not, but not everybody has it. And if you ask everybody if they're a bit tired and a bit stressed, they'll all say, yes, we are, so we must be burnt out. But what really characterises burnout is depersonalisation, which is where you actually completely detach. You lose your concern about others, you become cynical, and you become exhausted, unproductive. And it's probably a version of post-traumatic stress, but it's not exactly the same thing. But depersonalisation is a very specific thing. And what it results in is that you double your risk of providing unsafe care, behaving in an unprofessional way, and patient dissatisfaction reports. Now, this is a symptom not of individual problems, but of a broken healthcare system. And with the increased stresses, that's a very big issue. And this was taken from a meta-analysis of 47 studies on burnout, and a lot of those are very recent studies. So this is across the board. So how common is it? Well, this is where the problem rises, and this is an answer to Liz's sort of face. They did a meta-analysis of 100,000 people, 182 studies, and the range of burnout is somewhere between nothing, which is obviously an amazing, you and I want to work there, and 80%. And the characteristics that we say are important for burnout, somewhere again between 0 and 86%, 0 to 90% in low accomplishment. The problem was that there were also 47 different definitions of what burnout was. 31% for emotional exhaustion, 29% for depersonalisation. So we actually don't know what the definition is, so we don't really know what to make of these studies, which was kind of the conclusion. But that's not really the point. Who really cares? Because we clearly do have a problem. If these people are reporting these, if people are feeling burnt out, if people are feeling any of this, then we have a serious problem. So I think focusing on metrics and something that's not about metrics makes absolutely no sense to me. And I think we need to move away from that. I like the idea of moral injury more. This came from the war veterans, and this is the death by 1,000 cuts, which I think is much more real for us. We don't like burnout. Burnout suggests we have smart, tough people. We've gone through exams, years of doing ward rounds, doing all of the stuff that's, over a long time. We're resourceful people. Burnout suggests failure. It's something you've just a little empty shell of yourself. So with moral injury, you consider leaving, but you don't. You stay there in a wounded, disengaged, miserable sort of way. And I like this phrase, it's a deep soul wound that pierces your identity, and it disrupts your confidence about your own ability to make ethical decisions and others, and to behave in an ethical way. And this is a result of compassion fatigue, of complicity, doing things that you don't think are right, and in competing demands where you're trying to do a whole lot of stuff, but you still don't feel you're able to meet your patient's needs as you should. So this need brings us nicely to resilience, which is the adaptive, skillful response to stress which motivates us to act. We need a certain level of stress that's healthy for us, and we need the stress because otherwise we wouldn't run when the pager went off, or every time the microwave beeps 3 times, I'm ready to run. And I think of it like the Goldilocks thing. You can have too much, not enough. What we want to aim for is just right. Or like the stress response. So we start off at an optimal level, and then a major stress comes, and as we get overstressed, then we over-respond, and that's moral distress. And then when we can't do that anymore, we drop right down, just like our cortisol levels, and we're burnt out, and we under-respond. So it's kind of just like that. So we need to think of ourselves as canaries in the coal mine. If you just blame the canary and say that canary was just not a robust one, you miss the point. So I think we need to stop doing these surveys about whether burnout exists. We're missing the point. We're trying to measure something that we know we have a problem. Why don't we actually start addressing the problem instead of constantly measuring that we've got one? And what we've got is very old systems in a very new age, and we need to adapt the system. We're busily adapting. We need to adapt our systems to make sense for this. We need to support the team rather than blaming individuals. Resilience is not a character trait, it's not what you or I have, it is a process, and our process is changing all of the time. And Neil talked about that ability to adapt and how we constantly adapt, and the resilience is part of that. We need a culture shift where we need to build up our team and get people to work to their strengths. So if there's something someone's particularly good at, put them in that role and get them to do that. We need to acknowledge the emotional impact of what we're doing, and days when things are just too tough. We need to actually say so, and we need to say, today I'm finding this really tough. And I describe those as wuss days. Even my cat has them. Some days my cat follows me around. He's having a wuss day, and you think, that's okay. Tomorrow he'll be really robust and chasing the canaries again. We need to be going for a proactive rather than reactive strategy. So up to now, most of what we've done has been reactive. We have events, we debrief them. Things happen, we talk about them. We do root cause analysis after the event. We need to be doing Neil's thing, the safety 2 thing, where we say, what are we going to do in advance to prepare for us for this, to actually make this a better way to go? So we need to be thinking positively and forward rather than being the ambulance at the bottom of the cliff. So how do we do this? First of all, we acknowledge we've got a problem, and we stop thinking about business metrics. Next, we say we want to create a healthy environment, and we're going to focus both on ourselves and on validating the feelings and perceptions of others. And we're not very good about doing that. We know how we feel, and we're thinking about how things impact on us. We need to think about how our actions impact on others and on each other. And we need to value the talent. And we need to tell people that we value their talent. And that means not just praising the person that you see as in a position lower in the hierarchy, but praising your colleagues at the same level, or the people that you see as higher up. I really like telling John how brilliant he's done at things, because he always looks surprised every time. I think he doubts my sincerity. I don't know why. We need to have the courage to act on our own beliefs, to advocate for people, to be true to ourselves. If you really don't think something should happen, speak up. We need to be assertive, but we also have to be accountable for saying that. So you can't just say stuff and then just walk away. That's the passive-aggressives that Neil doesn't like. We need, if you make a statement, you need to stand by it and explain why and be accountable for that. We need to cognitively reframe, and that's putting in positive for negative thoughts. Think about what's the best thing that happened in your day, not the worst thing. Some of our colleagues are more Aspergian than others, and we still need to think that people think in different ways, and we never know what's going on for a person and why they might be more detached on certain days than others. Mentorship and supervision. Mentorship is a lifelong process. We mentor our trainees, and then we're on our own once we've qualified. And that doesn't matter whether you're medical, nursing, anything else. Once you're qualified, you're on your own, go for it. Every other discipline in a high-intensity field has supervision. Why don't we? And it's still not part of our culture, and I think it should be something that is there and expected of people that you opt out of, and everyone should have the right not to do this. But I think that this should be a standard of our culture, and we should be promoting it. And then there's self-monitoring systems. And after the Manchester bombing, Gillian Colville and Stephen Playfair modified a little app that the staff could self-check. And the one was for depersonalisation, the other one was for post-traumatic stress. And you could put how you were feeling that day into the thing, and it would give you a score. And what they found is that most of the people were really worried they were getting burnt out. And when they put it into the app, they found that they weren't, and they were so relieved that they weren't that put them in a really good frame. So it had a really... So the self-checking is actually, sometimes we worry and we're too scared to say anything, and if you did go over the line, there was a thing about how to seek help. But actually checking in on yourself and actually being aware of how we're feeling is important. That doesn't mean we're constantly navel-gazing and thinking about how we feel every single minute. But if you're getting worried when you're actually feeling detached, that's an important thing for us. We need to address institutional practices that perpetuate distress and prioritise the strategies that are good for our particular unit. And we need our staff to be doing that, everybody together. We don't need to be told what you will do, what will help you. You need people to be telling you what they need at the time, and encouraging everyone to raise ethical concerns. And we've just started in our unit planning to do monthly sessions where we take a couple of cases and talk about the ethics behind that and what were the issues for people, what were people worried about, and get people to understand the process of how you can come to decision making, which will be different for everyone, but that it's not completely random. We need healthy systems, and there's a whole lot of different forums for problem solving. So we have our family meetings and interdisciplinary rounds now, but they have, in the UK, they started peace rounds, which were weekly rounds where they align goals of care for their long-term patients. So they're not looking at the actions, they're looking at the philosophy for those patients. There are rounds where they have ethicists and psychologists coming and taking the moral and emotional pulse of the team once a week. And that's a different focus. That's what are we actually addressing? Do we think what we're doing is appropriate? Are we thinking we're actually doing things we shouldn't? And if we are doing those, how are we going to reframe it so we can either live with it or change it? We need to be doing more teaching, educational thing, and the simulation needs to be proactive, not reactive. So we're doing technical sims now and CRMs. We don't do a lot on communication. There are courses if you're in a training scheme, but we should, if you've got a difficult conversation coming up, having a situation where you can go and practice that ahead of the time. And Heather Duncan in Birmingham is doing a thing called Prepare, where that's what they do. Each person decides what they want to practice, and you go in and practice in a simulated session first. Things like the pause, where you stop after a patient's died after resuscitation. Everybody stops for a minute and just reflects on that person and their life and what that meant and what it means to be human and to be there when someone dies. We don't do that. We just carry on, and sometimes we give people breaks, but actually really reflecting on what we are dealing with. And then the failure bow, which is where really senior people admit to something they did that didn't go well and talk about how that was, so that your juniors can see that actually you're not invincible and you don't always have to be right. And then ethics consultations. Ethics committees should be involved very early on in decisions and in difficult sort of situations. They shouldn't be called in when it's all gone horribly wrong. Now, can you come and just reaffirm what we've already decided? They should be, if there's something people aren't sure about, get the team in and talk around the different things, because you get different perspectives, and that's the whole point. Everybody here today has come here with their own story about what happened today, what's going on at home, about experiences that you're relating to as we're talking about this. And everybody has a story, and understanding other people's story, it makes a really big difference. So when people are reacting in a certain way, why are they doing that? Not just they're grumpy today, but there will be something. And we had a patient which triggered off a personal event for one of our trainees because she'd had a very close friend with a very similar situation. And I think unless you actually share those stories, you don't understand why people are where they are, and you don't actually support them well enough. So what do we do now? Well, our world has changed hugely, and we cannot stay in the same way. We need to address the reasons for burnout, and the big thing is about humanity and connection. We need to foster our community, and that means that we value not just our patients, but each other. We need to value our staff, we need to value ourselves. We need to be listening to understand each other's perspectives, and as Liz said, we listen to understand, not just to respond. And there's a massive disconnect between the expectations of society and our reality of what we're living with and working with. And we need to really think about that disconnect and how we reframe it. And what does society actually want? Do we want just to increase the survival, or do we want more than that? And I think the reason that families are pushing for more and more is the massive fear of abandonment, a massive fear of death. The only thing we ever see about death now is about zombies. It's all scary stuff. And so I think what we're really seeing is people's fear. And I think what we need to do is to tap into that and actually address their real concerns. And that's what advanced care planning is trying to do, but I think it's actually at a deeper societal level from that. It's about isolation. And social media. Social media was an absolute disaster for those cases in the UK. But Jacinda Ardern, our Prime Minister, she uses it very effectively. She's constantly on Twitter, tweeting. She presents a very positive thing. She's demystifying things. That's what we need to do with social media. We need to tap into it. So as we've been sitting here, we're on Twitter sending messages out that all our friends around the world are getting the messages that are here. We're sharing conferences. It's a big collegial network, and we need to be sharing those things publicly as well. So this is all about connection, about people, and reaffirming, we need to refine humanity in medicine. Our patients on social media are telling stories. They're telling really personal stuff, and they're talking about how it feels, and we come back at them with evidence-based medicine, statistics. This is how it is. We're so bound by confidentiality, we forget that actually we can be human and that we don't have to break confidentiality, but we can talk about impact on ourselves. We can be seen as human and vulnerable, and that we really care for our patients. Our patients want us to love them. We need to love them. We need to love ourselves, and we need to actually show that we're human, because that's where I think our biggest disconnect is. So ultimately, what is the most important thing in the world? He tangata, he tangata, he tangata. It is people.